Again, a great pleasure to be here and to discuss the use of advanced monitoring here in this domain. No conflict related to the talk specifically. And we will discuss mostly the invasive and perhaps less invasive, mostly the pulse contour and transperimeter dilution use in this context. And indeed, our society had indeed emitted recommendations that in complex cases we should use this, and our algorithm of the cardiovascular section is indeed to begin with echo when we can indeed have a lot of information there, but remember, one of the very important limitations of the echo is time for one single patient. When I do the echo, apply, measure, reevaluate, it takes me 25, 30 minutes. Yes, and I'm not doing anything else with the other patients, not talking to the family. Oh, I have to do a lot of things there. So indeed, it's good to have also some other monitorings there. So that's indeed why we also want to have aspects that can be nurse-driven and that indeed can not only be specifically dedicated to the doctor evaluating the echo, interpreting and making all those things. So with a PA catheter, a very rapid reminder, because I'm afraid that some of you may not have used it, maybe have forgotten a little bit what we can have with that, is a cardiac output, the pressures, right and left, and pulmonary artery pressure, and of course the SVU2. And this helps us to have the evaluation of the cardiac output, its adequacy, preload, and pulmonary artery pressures. With the transperimeter dilution, we have access with some measurements of cardiac output as an intermittent one with the thermodilution, of course, but also a continuous one with the calibrated pulse wave analysis. And we have also derived measurements of the volumes and extravascular water. And all these together, again, help us to have an idea of the cardiac output and its adequacy, the preload, and not the pressure is here, but the lung water that would indeed be an important factor. And you can have some interesting applications detailed in these kind of review papers. So the usefulness of these two techniques is perhaps in the diagnostic approach, but probably much more in the continuous monitoring and evaluation of response to therapy, and I will discuss this, because indeed with the echo, really, we have the gold standard to make our fine-tuned diagnosis there, and we can really have, when we have left heart dysfunction, we can know exactly what is the problem. Is it the pump? Is it the valve? Is it the combination? I mean, we have really a very good diagnostic tool, but again, changes over time may be a little bit more complicated, and we often discuss this with Antoine Verabamon. I mean, you do how many echo per day? Well, I do, basically, if you do one echo per day, it's already quite a lot in many of your patients. So at the end, that's a little bit limitation, and in between, the patient may change, and that's why it's good to have some other devices that can be useful. Then the question is, of course, how to select between the two, and for this, of course, we have this kind of papers. The most important aspect to remember, well, cardiac output? No. That's exactly the same type of measurements. Validity is not questioned. Well, the preload, yes, you assess it a little bit differently, with the filling pressures on one hand, affected by the intrathoracic pressure, admittedly, and on the other hand, we have volumes, but then the question is that we do not make the difference between the right and the left volume. We have a total volume of the cavity, and especially when we will begin to have right heart dysfunction, well, we will miss this aspect, because indeed, we have a volume which is representing lumping the left side and right side. So that's a little bit some limitations there. But again, because you do the echo, also you already know in advance whether you are facing right or left ventricular dysfunction. So that's why combining the echo and the other devices is quite good. And my way to practice, and some others like Michael here, because we wrote together this paper, is indeed that we identify with the echoes a way to better select between the two techniques. But we can still make it quite nicely with just the transparent hemodilution and repeated echo, of course, in many of these patients. And then, of course, we have the measurements or estimation of the risk of pulmonary edema with the lung water on one hand and the filling pressure on the other hand. And this is interesting, of course, because both have PAOP and the extravascular lung water are associated with a poor outcome. But these represent really different things. And remember that the pulmonary artery pressure is really the driving force of the hydrostatic pressure, so the force that makes the water leaving the capillaries and escaping to the interstitial space and alveolar space, while the extravascular lung water is the extent of the flooding. So sometimes, I mean, when you are outside, you see a difference between it's raining, and indeed, sometimes you see the ground is wet, but it's no more raining. So indeed, when the dynamic changes occur, it can be something very important there. And both have intrinsic value, and you can not really say that one is better than the other one. Pulmonary artery pressure is, of course, a very important aspect, and sometimes it's debated its value with echo. But more importantly, what can we do at the bedside with it? Well, we can, of course, detect fluid responsiveness. But this will be covered by the next talk, so I will rapidly stop here. I would just want to say that with or without echo, you can still have the respiratory variation in stroke volume that can be detected by the pulse control mostly, and you can also do the expiratory inspiratory pause, again with the pulse control. With a PA catheter, you are limited there. Admittedly, you cannot really do this. But perhaps the most important aspect is that when we give volume, especially in our RDS patient, it's important not to focus only on the predicting the response to fluid, we also need to evaluate the response to fluid. And with that, it's important again to have these devices that help us to integrate whether or not we have some beneficial effect or we need to stop right away to continue to give volume in these patients. And also we have many other conditions where indeed we can see that these functional hemodynamics can be useful from the perioperative to the emergency department, the ICU state, all these we can indeed have very nice use of these, trying to fine-tune not only the volume assessment but also the heart-lung interactions in a broader sense there. Because indeed, we may discuss here the diagnosis of the acute coropulmonale. And this again, we need to go back for the basic interpretation of PA catheter data. We need indeed to remember that we assess volumes indirectly with pressures. And so in normal conditions or in normal situation, we have indeed always the pulmonary arterial occluded pressure, which is 2 millimeters higher than the right atrial pressure. And what occurs when we have isolated left heart dysfunction, elevated left atrial pressure, elevated PAOP, but no more changes in CVP. While, on the other hand, when we have right heart dysfunction, we have there equilibrium and then this CVP or right atrial pressure that becomes higher than the pulmonary arterial occluded pressure, which may slightly increase because indeed the ventricle is squeezed by the right ventricle also. And in global dilation, we have elevation of both pressures, but again, the pressure in the left heart remains higher than the pressure in the right heart. And with the pulmonary artery catheter, we can even have a more fine-tuned aspect to identify where it is a post-capillary issue, increase in left atrial pressure, or a problem in the resistance in pulmonary capillaries, which is again something very important by just looking at the difference between the diastolic arterial pressure and the pulmonary artery occluded pressure. So, what is exactly the incidence of the acute coropulmonale in RDS? Well, with echo, we know it's around 20%. Interestingly, when you use a PA catheter, and these are data from Christian Richard, when they looked at this with the PA catheter, it was around 10%. So 10%, 20%. Oh, there is a difference. And this was already covered in the debate yesterday. But the question is, why? Well, it's really clear. I mean, distension occurs before the rise in pressure. So when you see and detect the rise in pressure, the volume of the right heart has already initiated its enlargement. So the question is, of course, when you detect it, with the PA catheter, it's much more advanced than when you detect it with echo. So probably when you see in the echo, sometimes you just need to be cautious and not need any other intervention. When you see it with a PA catheter, probably you need to intervene in these kind of patients. How to suspect the acute coronary without echo? Of course, you can have already some ideas. And some ideas when you look at pulse pressure variations, indeed, and when you see that these patients fail to respond to fluid. And this can be done by looking at giving fluids. It can be also done by doing the passive leg raising test and seeing whether you increase cardiac output or not in these patients. And you can see that indeed in these patients here, the pulse pressure variations were exactly identical at baseline in the patient who had responded to fluid and not a patient not responding to fluid. And the echo here was interesting to disclose that indeed these patients here, the non-responders, had really a dilation of the right ventricle, which was not the case in the other patients. So indeed, right heart dysfunction may at least partly explain these factors. And indeed, another interesting data here from a Yuka Takada group, where they indeed also had looked at patients with pulmonary hypertension in sepsis in that group, and they realized also that the CVP, together with the pulse pressure variations here, was helping to identify the patients who will or not respond to fluid. And the patient who failed to respond to fluid indeed had a higher CVP there, suggesting that the pulse pressure variation in that condition was somewhat related to right heart dysfunction. So it's, of course, relatively not very fine, but with PA catheter, we have indeed the ultimate aspect, which is the right atrial pressure higher than pulmonary arterial fluid pressure. With transfemoral dilution, it's a little bit more complex. It's the high CVP together with some pulse pressure or stroke volume variation that help us to suspect it, and of course it's good in these conditions to do the echo to confirm it. The most important aspect is perhaps to look at the impact of the heart-lung interactions. And for this, of course, again, this paper, an essential paper in the literature of Peter Suter, where indeed they looked at the impact of PEEP on cardiac output. And very importantly, they identified that at some point there is a peak in the oxygen delivery, which is the optimal PEEP. And then it decreases because there is a decrease in cardiac output due to hyperinflation and so on and so on. But the most important aspect is that we have here a way to combine the best point for the lungs and for the heart when we apply the PEEP in these patients. And also this essential paper of Jean-Loup Teboul, who was really performing the data at the bedside with François Lemaire. And so indeed what they saw again is the impact during weaning that we can have with the PA catheter. Can we also have some ideas with the transfemoral dilution? Yes, we have. And in this very nice paper here, we can see that indeed the patients with weaning-associated pulmonary edema also had here some interesting findings, because indeed the changes in cardiac index were totally different in the patient with pulmonary edema induced by weaning and the patients without it. And you can see also that the changes in extravascular water during weaning attempt can also be important to identify patients who had weaning failure from cardiac origin in this context. The next point is, of course, the continuous monitoring, which is, of course, something totally obvious, but very important for many of these patients, and the evaluation of response to therapy. I mean, this is one of these trials showing that indeed, when you give inhaled NO, you can really look at what are the beneficial effects. And remember that one of the most important aspects here is that, yes, there was some improvement in pulmonary artery pressure, there was some improvement, in oxygenation, but there was no change in cardiac output here, meaning that this patient had indeed some pulmonary hypertension, but no significant right heart dysfunction. So again, a good way to identify and to look at these patients, and to look also at perhaps the beneficial effect of the therapy in these conditions. And here, another explanation, right heart dysfunction, impact of levosimendan in these conditions. We may discuss the use of additional variables like the PAPI, which is a little bit the ejection fraction of the right ventricle, because it combines the impact of stroke volume on the pulsatility, but also the compliance of the vessel and the right ventricle function and the right ventricle preload. So a mixture of everything there that on the long term can be useful there. And the final aspect is that also we can understand the crosstalk between the organs, and sometimes when we do something good for one organ, we can do something bad for the other one. And so, of course, just think at when we increase PP in our patient, we optimize lung recruitment, we improve PO2, we minimize injury, that's fine, but also we have some impact on cardiac output and on tissue perfusion. And also something not really discussed up to now is the increase in venous pressure, which also decreases tissue perfusion. Sometimes we give volume in these conditions, that's fine. We may help indeed to improve cardiac output, but then we also have some impairment in venous return, and this also that's not always that good. So we need to integrate all these factors, and that's why I think that it's good to have not only these advanced hemodynamic devices, but also, again, to have the ultrasound at least from time to time to look at all the consequences, not only in the heart, but also in the peripheral veins in these patients. And with this, I thank you for your attention.
I think this was a great overview, integrating the echo and the hemodynamic monitoring, and kind of preparing us for the next talk. I want to give the audience the chance to ask a question. There's a question there.
Don't worry, Daniel. I pretty well agree with everything you said, and I really liked it. But I want to emphasize something that's really clicked in my mind recently, and I published on this, in the concept of RV limitation versus RV dysfunction. And echo can't pick up limitation. So dysfunction itself, if you have diastolic reserve and you haven't reached that wall, the limit, you can handle it. But if you then have a rise in PA pressure, you'll have a problem. If there's a demand for higher cardiac output, that's a problem. So the real issue is RV limitation, not dysfunction, because you can even do it with a normal heart. And once you hit that limit, then that totally changes the physiology. And I mean, the only thing I would slightly disagree with you, because you had that curve, it's a sharp break. And you cannot pick that up with echo until you've really overdone it. The septum's over. You actually made that point. You're not going to see it. So I like the limitation concept, because the numbers just changed with that.
Thank you for the comments.